We're just waiting for a couple more people to join. We're going to be starting in 1 minute. Thank you to everyone who has joined so far. We're going to be starting in 1 minute, just waiting for a couple more people to join before we start. Okay, hi everyone. Thank you so much for joining us tonight. My name is Dr. Mimi Knoll, and I am a radiation oncologist at Montefiore Nyack Hospital, and I'm president of JOWMA, otherwise known as the Jewish Orthodox Women's Medical Association. As you might know, our members are physicians, women physicians, and physician trainees. And one of the goals of our organization is to provide evidence-based medicine geared towards the Orthodox frum community. And our goal here tonight is similar in that we have initiated a women's health webinar series. You may have joined Sunday night for our first session, Monday night for our second session, and tonight is our third session. And tonight we're going to be covering an overview of topics related to women's gynecological health. And we really want to thank our generous sponsors who have sponsored this event, and without whom this event would not have been possible. J-Screen, Sherman Abram Labs, the Jewish Fertility Foundation, Extend Fertility, and Touro College. Thank you so much for being partners with us in promoting women's health education. I want to hand the floor over to our moderator tonight, student Dr. Ben Ayun.
Hi, everyone. Good evening. It's nice to see so many people here. I'm student Dr. Jackie Benyun. I'm a medical student at SUNY Downstate in Brooklyn. Before we begin, I'd like to inform you that we will have a question and answer session after all of the speakers finish speaking. So all questions should be posted in the question box. If you would like to have your questions remain anonymous, please hit the Remain Anonymous button. Otherwise, your name will be visible. There will be no option to post in the chat box. Also, you'll notice that every person viewing the webinar is anonymous and you cannot see the other attendees that are on this webinar. So your presence, again, is completely anonymous, okay? Your video and your voice is not enabled. Again, when you're asking a question, if you'd like to remain anonymous, sorry, we keep emphasizing this, but just click on the Remain Anonymous button. Access to the recorded session is going to be available to all those who are registered after the event. So I'd like to start by introducing you to our first speaker, Dr. Batsheva Maslow. Dr. Maslow is a reproductive endocrinologist and infertility specialist at Extend Fertility and Premium Health Center. She also has a master's in clinical and translational research and is the director of research at Extend Fertility. Additionally, she serves as the director for medical education of the North American Yoetzet Halacha program and sits on the founding board of directors at JOWMA. Without further ado, Dr. Maslow.
Thank you so much. Thanks everyone for coming. It's just really exciting to be able to do this. Now this is my second night speaking and we have some amazing topics this evening. We're gonna get started with our first topic, which is discussing female fertility decline and egg freezing. As you heard, my name is Batsheva Mazzo. I'm a reproductive endocrinologist. I work at Extend Fertility, where we really do have a primary focus on egg freezing. And so I see a lot of patients, especially women in the FRM community, who are interested in learning more about their fertility and the way fertility declines with age, and how egg freezing might be able to help women achieve their goals. I have no financial disclosures. I'm going to emphasize again that conversations this evening do not constitute individual medical or halachic advice, and they should not substitute those conversations with your personal medical or halachic authority. So tonight we're going to try to address these objectives. How and why do female fertility decline with age? What are some of the ways we can assess fertility, and how can egg freezing be an effective tool to improve the chances of meeting reproductive goals? So there's really two ways in which age affects fertility. The first is egg quantity. So as women, we're born with all the eggs we'll ever have, and eventually we run out of eggs when we go into menopause. Kind of where we are on our slope towards menopause is one aspect of our fertility, but actually often not the most important one. Because when somebody's trying to conceive, there's just one egg that the body selects to be available for pregnancy each month. And ultimately, it's the quality of that one egg or the DNA that's inside that one egg that determines whether or not that's going to be a month in which somebody can conceive. And as we get older, more and more of the eggs start to develop abnormalities in their chromosomes so that they have either too many or too few chromosomes. And those abnormal eggs tend to just not work. So that would be a month if an abnormal egg was selected that typically somebody just wouldn't conceive. Occasionally, those abnormal eggs do conceive and may end in an early miscarriage. Ultimately, egg quality is really one of the most important factors that leads to infertility as we get older. This is just a demonstration with some data from the Society for Assisted Reproductive Medicine using IVF data and looking at abnormal embryos as they reflect the eggs that they came from based on age. So up to 85, almost 90% of eggs that come from a 25-year-old have a normal number of chromosomes. At 35, it's about 50%. And if you look at 45, it's less than 10%. And this is one of the reasons why 35 gets a little bit of a bad reputation when it comes to fertility, because that's the point in which most women sort of shift from having mostly normal eggs to having mostly abnormal eggs. That being said, a healthy egg at 40 is just as good as a healthy egg at 30. There's just fewer of them around. And so what we see as a result of the decline in egg quality is that on average, the time to pregnancy will go up, right? So it will take more months to conceive as women get older. And what you also see is that infertility goes up. And partially that's due to the fact that we define infertility as having tried for a year without success. So as women get older, more and more of them will fall into this category, mostly because more and more will go month after month with having abnormal eggs that are selected that month for pregnancy. Along with all of this, we also have a slightly increased rate of miscarriage and Down syndrome for the same reason. So, and I spoke about this yesterday, the vast majority, greater than 90% of miscarriages are caused by chromosomal abnormalities in the fetus that typically trace back to usually the egg, although occasionally it's the sperm. And so what we start to see is that miscarriage rates go up as well as we get older. So you can see in this graph, it goes by month, the likelihood of getting pregnant. Year by year, the likelihood of getting pregnant and the likelihood of experiencing a miscarriage. Down syndrome, for example, is a syndrome that's caused by an extra chromosome 21, which is one of these chromosomal abnormalities. And so along with all of these, we do see a slightly increased rate of Down syndrome as women get older, although it overall is still quite rare. Many women say, okay, so infertility increases as we get older, but we have IVF now. IVF is an excellent treatment option. It has allowed for now over 8 million babies to be born over the last few decades. Those are all families and babies that would not have been available, not have been created had it not been for this new technology. So IVF is really a fantastic technology that has really changed the world for a positive way. But IVF is always going to be limited by the quality or the age of the eggs that are being used. And so what you see here, this is also data from the Society for Assisted Reproductive Technologies. The green bars, or the teal bars, are IVF pregnancy rates using own eggs. And now this is older data, so I don't pay too much attention to the actual numbers. Pregnancy rates for women under 35 are well above 40% at this point. But what I like about this graph is that it demonstrates the decline. So you can see that as women get older, their chances of success with IVF decline. Now, the purple bars are looking at women who utilize donor eggs. So these are women who maybe have exceeded their opportunity to get pregnant with their own eggs, or they don't have eggs anymore. Maybe they've unfortunately gone through early menopause, who are utilizing donated eggs from a younger woman. This is typically women who are under the age of 30. And if you look, the pregnancy rates with these donor eggs are essentially the same no matter how old the intended parent is. So what really is driving the force behind infertility as women get older is the eggs rather than the ability to carry a pregnancy. And this is really the foundation upon which the concept of egg freezing is built. Because what egg freezing allows you to do is to preserve your own eggs at a younger age, so that if you were to experience infertility in the future, you can rely upon your own younger eggs rather than either your own older eggs or somebody else's eggs. And this is a graph that we like to use in our office a lot. We compare we like to compare the ovary to a gumball machine. So when we're young, there's lots and lots of gumballs. The ovary is filled with eggs, and most of those gumballs are good, right? The blue ones. And so if you were to turn the knob and expect one gumball to come out at random, like we have for ovulation each month, it's almost always going to be a good one. And every once in a while, it will be a green one. But most of the time, what you're getting is the good gumball. So there's a high quantity of eggs, and most of the eggs are chromosomally normal. As we get older, you see two shifts. There are fewer eggs, and more of them are chromosomally abnormal. So when you turn the knob for ovulation, the chances that a blue egg come out or a blue gumball come out are much lower, but not zero. And so those blue gumballs, like I said, are the same at 40 as they were at 30. There's just fewer of them available. Now, the big question that everybody asks is, okay, can you test egg quality? So if I'm gonna freeze my eggs, how do I know if my eggs are any good? And this is a real challenge with egg freezing, because the egg is just a single cell. It's the largest single cell in the human body. It's quite remarkable how big it is compared to all the other cells. But you can't remove the DNA from inside this one cell without actually essentially destroying the cell in the process. So we can't test for egg quality. Once eggs are fertilized and they ultimately grow into embryos, they get to a stage in which they have hundreds of cells, and you actually can select a few cells off the surface of the embryo. And I actually had some pictures about that last night, where you can test the cells from the surface of the embryo, and that's a good way of getting an idea of the DNA and the chromosomes of the remainder, the whole embryo as a whole. But without that testing ability at the egg stage, meaning most women who are seeking egg freezing don't have the opportunity to fertilize their eggs, you have to think about freezing enough eggs to compensate for the fact that some portion of them are going to be abnormal. And for many women, the majority of them are going to be abnormal. And so we use age to help us get a sense of what the likelihood is that there will be healthy eggs in the group that women are able to freeze. And what we see is, because of the increase in abnormal eggs, live birth rates per egg are going to go down with age, which makes sense with everything I've already talked about. And therefore, older women may need more eggs to secure the same level of success as a younger woman. To put it in a different way, somebody who's 30, who's doing egg freezing, who freezes 10 eggs, has about a 65-70% chance of having at least one baby from those 10 eggs. Somebody who's 39 who freezes 10 eggs only has about a 45, maybe 50% chance of at least one baby. 42, it's only about a 25, 30% chance. So what you start to see is that as women get older, they may need more eggs to get to that same level of success. But unfortunately, as women get older, they aren't able to produce as many eggs, because the biggest factor in terms of how many eggs somebody can produce in a single egg freezing cycle is going to be each person's individual egg supply. And as we know, egg supply goes down with age. Egg supply itself, or egg quantity, really doesn't tell us much about any one individual's ability to get pregnant. There's been some great studies that had looked at women who were trying to get pregnant, and they tested their egg supply, and they sent them out to get pregnant in 6 months, and they came back, and egg supply really couldn't predict who was going to get pregnant and who wouldn't. There are some other studies that maybe it's an indication of future risk of infertility. But the truth is that we have very poor ways, actually, we don't have really any good ways of predicting who can conceive and who can't. I talk about this all the time, about how much I wish we had some risks, what we call risk stratification. In other elements of medicine, we have, this risk factor and this risk factor, and you put them all together in an app, and it gives you like a spit out a number and says, okay, this is your chance of having an osteoporotic fracture in the next 2 years. This is your chance of having a heart attack in the next 5 years. We don't have that for infertility. We can't say, okay, this is your chance of having a baby in the next 5 years. I wish that we did, but we don't. There's so much variability, and there's so much that's hard to predict. So having a high number of eggs, unfortunately, doesn't protect us from the rates of infertility that increase as we get older. But having a low number of eggs doesn't necessarily induce infertility either. These assessments are most useful when you're thinking about either egg freezing or IVF, and it's a way to help give somebody realistic expectations for how many eggs you can anticipate from the egg freezing process or an IVF cycle. Oh, we're going to get to my next slide. There we go. So how do we measure egg quantity? The best measure of egg quantity is a hormone level called AMH, or anti-Mullerian hormone. It's by no means perfect. It has a lot of flaws. It's not as, it's just not as precise as we would like it to be, but it's the best thing that we have right now. Anti-Mullerian hormone is a hormone that's produced by the eggs themselves. So the more eggs you have, the higher this hormone level is going to be. What I wanted to demonstrate in this graph is not to kind of overwhelm you with this weird looking graph, but really to point out the variations that you see from age to age. Look how wide the variation is at 25. It goes from 2 to 11. And even at 43, it's going from 0 to 3. Basically, right? So there's a really wide range. And that's why I always tell my patients, there's no such thing as a normal AMH. And there really isn't such thing as an abnormal AMH either. I like to use averages or medians per age to help guide me. Is this somebody who's likely to respond in a typical fashion for somebody their age, likely to respond more briskly or more robustly or less? And then adjust my treatment options. Like, it's somebody who has a lower AMH is someone might be more aggressive with, and somebody who has a higher AMH is somebody we might not be quite as aggressive with. The other way to measure or assess egg supply is something called an antral follicle count. That's done with typically a transvaginal ultrasound, typically performed by a doctor or a trained sonographer, where you look at the ovary and you count all these little black dots. So I like to tell people that ovaries on ultrasound look a little bit like chocolate chips, partly because I just really like chocolate chip cookies. And each of these little chocolate chips is this little follicle or a bubble that contains an immature egg. And Dr. Wertheimer mentioned this yesterday. At any given time, there's going to be a group of these follicles that come to the surface of the ovary. And the brain will naturally tell the ovary to select one follicle to grow each month, and the remainder essentially just get discarded by the body. And when we do processes like IVF or egg freezing, what we're trying to do is stimulate the growth of all these other follicles that otherwise would have been discarded. So the question I often get from women who are thinking about egg freezing is, am I stealing from my future eggs? Am I somehow, if I preserve 12 eggs, am I going to go into menopause a year early? And the truth is that that's absolutely not true, because what we're really doing is growing and capturing the group of eggs that you otherwise would have lost. So it has no impact on your future fertility. There's been lots of good studies that have demonstrated that. And the antral follicle count is also, not as precise as we would like it to be, and that's why we tend to use both together. They usually go hand in hand. If you have a high AMH, you tend to have a high antral follicle count, but sometimes there are discrepancies, and that's why it's best to have these results interpreted by somebody who's really comfortable with these tests, because just looking at a single AMH or a single antral follicle count can sometimes give you, a skewed view of what you can expect, and it's great to really have somebody who's really comfortable with those results. So what does egg freezing actually do? The egg freezing, and truth is that freezing is a little bit of a misnomer. It's actually something called vitrification. So what we first do is dehydrate the egg. Remember, I told you the egg is the largest single cell in the human body, contains a lot of cytoplasm, a lot of water. And if you freeze it just the way it is, it creates ice crystals. And those of you may remember from like high school science that water, when it freezes, expands. And if those ice crystals expand inside the cell membrane of the egg, it breaks apart. And so what you actually need to do is vitrify the egg. You dehydrate it first, and then freeze it in a very fast fashion in liquid nitrogen. It goes down to minus 196 degrees centigrade. And at that temperature, there's no molecular activity, no metabolic activity at all. So the egg is literally frozen in time. And what egg freezing as kind of a process allows you to do is to freeze the eggs at the quality they are, the DNA that they have at that age, and also batch together a large enough group of eggs that you can use the quantity to your advantage. So what do you need to know when you're thinking about doing egg freezing? It's always great to have a consultation with a physician. The sooner you have the consultation, the better. You can always decide this is not the right time to move forward, but the knowledge will help you guide you as to what makes the most sense for you. And, I cannot tell you how many times I have patients who are, I wish I knew this earlier. I wish I had this information earlier. I wish I could have known to do this, X number of years ago. The knowledge is going to be extraordinarily valuable, even if it's something that you're not ever planning to pursue. And so the information you'd like from a physician is roughly how many eggs can someone like me expect to freeze? And what are my chances of having a baby with that number of eggs based on my age, right? Those are the two factors, the quantity plus the quality. And then armed with this information, you should consider your own personal goals. What are your reproductive goals? How large of a family do you want? Today I posted on my Instagram, like a shameless plug for my social media, but I posted today that, in the Orthodox community, frum women are often thinking about having large families, and large families take time. It takes years and a decade or more to grow a large family. And if you start that process late, then you may not be able to achieve those goals. And so sometimes egg freezing may not be for somebody who's going to experience infertility with their first pregnancy. Maybe it's an opportunity to save it for a second or a third or a fourth that they may not have otherwise been able to have. Once you've kind of have an idea of what your reproductive goals might be, think about how many cycles it might take to meet those goals. Egg freezing is expensive. It's time consuming. It requires a lot of resources. You have to make sure that that's feasible for you, right? So for somebody who, let's say, has a very low ovarian reserve and may only produce 2 or 3 eggs per cycle, but, based on their age, they would want 15 or 20 eggs to get to the goal that they need. It's not reasonable to expect that you're going to do an egg freezing cycle 5 or 6 times. And that's, you have to kind of have an honest discussion with yourself about, does this make sense for me? Is it right for me? And then is now the right time to move forward, right? There are some people for whom it makes sense to be urgent about it. And there are others where it makes sense to say, you know what, if you came back to see me in 6 to 12 months, we're going to be having the same conversation with very similar numbers. And so if now is not the best time, waiting 6 months is probably not a huge sacrifice for you. So those are the types of questions you should be asking yourself and your physician, and really trying to sort it out so that you go into this process not by default, but from a position of power, from a position of knowledge, not like, oh, I have to do this, but that you're choosing to do this because it makes the most sense for the goals that you have.
Dr. Maslow, 2 minutes left.
Perfect. I'm going to spend my last 2 minutes just summarizing what the process is actually like. It's about a 2-week process, typically starts with the beginning of your period. We have you take, stimulation medication. So these are hormonal injections that we typically teach our patients how to give themselves. These are the same hormones the brain is using to regulate the menstrual cycle. It's just in higher amounts. So instead of the ovary picking one egg to grow, it's hopefully going to pick 8, 10, 12, 15, whatever the maximum number we can get each ovary to do. And remember, don't compare yourself to others, because everybody's body is going to be different and everybody's going to be limited by what their ovaries can produce. Now, if you look here, here's a transvaginal ultrasound of an ovary that's been stimulated. You can see how different it looks from the one we showed you earlier that had like the little chocolate chips. These are now like big chocolate chunks. Once it looks like you've grown as many eggs as we think you're going to be able to, we have our patients take something called a trigger shot. The trigger shot is what starts the maturity process for the eggs, and 36 hours later, we do the retrieval. The retrieval is done, is a procedure. It's usually done in a procedure room. Typically, those procedure rooms are in our office, so they don't need to necessarily go to a hospital. It's a very minimally invasive same-day procedure. It takes about 15, 20 minutes to do. We do it under anesthesia, the same kind of anesthesia someone might have for a colonoscopy or an endoscopy. We use a needle through the vaginal wall, so there's no incisions and there's no stitches, and we stick a needle into these follicles and we draw out the fluid that's in them. If you look at this picture, this is a tube of follicular fluid, and that's what it looks like. And under the microscope, there are all these cells, and this big one here in the center is the egg. And so we identify the eggs, we isolate them, we wait for them to mature. So maturity is a physical characteristic that the egg develops under the microscope that signifies that it's able to be fertilized one day. And then we cryopreserve those mature eggs. And this is sort of what it looks like in my lab. So here is an embryologist looking at a dish under the microscope, and you can see here just barely there's an egg here that's visible that she's about to load into her pipette. Here you have one of my embryologists placing frozen eggs into a tank of liquid nitrogen. And these are incubators that are used to keep the eggs before they are ready to be frozen. And that is the end, and I'll be available to answer some questions through the Q&A, and I'm going to pass it back to Jackie to introduce our next speaker.
Hi, everyone. So next we're going to hear from Dr. Leora Joel. Dr. Joel completed her residency in obstetrics and gynecology at Montefiore. Dr. Joel has been in private practice since graduating, and she recently joined Maternal Resources and Integrative Obstetrics, a private practice affiliated with Hackensack University Medical Center in New Jersey. Dr. Joel.
Okay, let's see. Okay, can you guys all see my slides? Thumbs up. Okay, great. Hi, good evening. My name is Leora Joel, and we're actually going to shift gears a little bit. We're going to be talking about abnormal uterine bleeding. So, and my next colleague is going to be talking about other GYN issues that you may encounter. So just again, I have no disclosures, and a reminder again that this presentation is not intended to provide information. It is intended to provide information, but shouldn't be used as medical advice or as a replacement for medical evaluations. All right, so in this presentation, I would like to start by delineating what a normal amount of menstrual bleeding is. Obviously, in order to discuss what abnormal bleeding is, it always is good to start with what is normal bleeding, what constitutes normal bleeding. When I use the term reproductive age women, I'm referring to all women who are between the age of menarche, which is when you first start menopause, and when you first start your periods, and then menopause. We're going to address the causes of excessive bleeding and the ways in which we can diagnose and treat it. And then we're also going to address the causes of less than normal bleeding, which is also known as oligomenorrhea, and the ways in which we can evaluate and diagnose it and treat it. So what is normal bleeding? A menstrual cycle is typically anywhere between 24 days and 35 days apart. And remember, it's really important to know that when we're counting menstrual cycles, we're counting from day one of a period to day one of the next period. When I ask my patients if they have regular cycles, I would say about 9 out of 10 of them will initially say no. But then upon further discussion, we often do clarify that in fact their menses are regular. They just don't occur on the same day every month, and that is okay. So what is the normal bleeding length? Usually the average amount of bleeding is about 5 days long, but anywhere between 3 days and even up to 8 days can be normal. And what's a normal bleeding amount? So a normal bleeding amount is up to 80 milliliters. So that's great. How is anyone going to quantify what 80 milliliters is? It's pretty difficult to visually quantify that or even really estimate how much 80 milliliters is. So I'd like to give some examples of what would be too much, what would be considered too much bleeding. So using more than one pad at a time it would be considered a lot of bleeding. Changing an ultra tampon, I'll admit that I didn't even know an ultra tampon existed until recently, but it just, the fact that they do exist does show that there are women who are having very heavy bleeding. So if you're changing an ultra tampon every 2 hours or several times at night, that's too much bleeding. If you're passing large blood clots, so you're passing blood clots that are the size of a golf ball or even bigger sometimes, that is too much bleeding as well. And then, are you becoming anemic because you're having these heavy periods? And then just for fun, to give an idea of what 80 milliliters actually is, this is a perfume bottle that is 2.7 fluid ounce perfume bottle that is equivalent to 80 milliliters. So when should you seek care for abnormal bleeding? If you're having bleeding in between periods, if you're bleeding or spotting after sex frequently, if you're having these very heavy periods, as we spoke about in the previous slide, if your cycles are outside the range of normal, so more than 35 days apart or less than 24 days apart, or if you're having irregular periods. So I know on the previous slide, I was talking about how regular periods don't have to occur on the same day each month. But if on a regular basis, your periods are fluctuating by more than a week every month, then that is still considered an irregular period or cycle. And then of course, any bleeding after menopause is abnormal. We're not really going to get into that much tonight, but that should always be evaluated. My patients often ask me, is abnormal bleeding common? So we do most commonly encounter abnormal bleeding during both ends of the menstrual spectrum. So shortly after your menstruation starts, and then during the years leading up to menopause, which is called the perimenopausal state. This finding is typically attributed to disturbances in the hormone pathways that are underlying the menstrual cycle. So we're not going to go into too much detail. I know Dr. Wertheimer spoke about this a bunch the other night, but we're just going to review a little bit. So we have a very detailed hormonal pathway, which is what allows us to have cycles every month. The hormone pathway starts off in the brain in the hypothalamus, which releases a hormone that then stimulates the pituitary gland, which is also in the brain. The pituitary gland then releases two hormones called LH and FSH. And these hormones feed the ovaries and stimulate the ovaries to produce estrogen and progesterone, which ultimately prepare the ovaries and the uterus for the release of an egg and the possibility of a pregnancy with each cycle. So in young women who have just started getting their periods, this whole hormone pathway is not yet matured or regulated. And therefore, we often see young women with irregular periods. And it's important to remember that that's part of normal development. In the same way, when women approach menopause, there are fewer eggs remaining in the ovary, and therefore there's less secretion of estrogen, which again leads to disruption in this hormone pathway and ultimately to irregular periods. All of that being said, abnormal bleeding really can occur at any age, and we're going to now go into some of the reasons that that may happen. So first, we're going to focus on what causes excessive bleeding. When we talk about excessive or very heavy menstrual bleeding, we typically divide the causes into two categories, one of which is structural causes and the other of which is non-structural causes. So first, we're going to talk about the structural causes, and they are typically related to abnormalities within the uterus itself. So let's go over a little bit of uterine anatomy. You can see here in this diagram that here's a picture of a uterus. The uterus consists of three layers. We have the uterine lining, called the endometrium. Then we have the middle layer, which is called the myometrium, and this consists of muscle tissue. And then the third layer is the surface layer, which is a shiny outer layer called the serosa. So different abnormalities can occur in these layers. Uterine polyps are extra growth or outpouches of the uterine lining here, as you can see. Uterine fibroids are extra growth of the muscle tissue or the middle layer, or the myometrium in the uterus. And then there's a condition called adenomyosis. And what adenomyosis is a condition in which cells from the lining of the uterus can actually migrate towards other parts of the uterus, and they can lead to very heavy and often very painful periods. And then lastly, the uterine lining as a whole can have abnormal thickening, which is often due to an excess in estrogen exposure. So now let's talk about some of the non-structural causes of excessive bleeding. A patient may have a bleeding disorder. And what does that mean? That means there are certain genetic conditions which can actually predispose you, that can lead to impaired blood clotting, which can thereby lead to heavier bleeding. And this, because it's genetic, it's something that usually manifests a little bit earlier in life. And you also may have some other kind of symptoms like frequent nosebleeds, frequent bruising, or even, after getting a small cut, you may have a prolonged bleeding period. Another non-structural cause of heavy bleeding is ovulation dysfunction. So we did allude to this in some of the other presentations earlier in this series, but essentially ovulation dysfunction is when there's any real disruption in the hormone pathway that we had talked about in one of the previous slides. So any disruption in that pathway can lead to abnormal bleeding and heavy bleeding. There are also certain methods of birth control that can lead to heavier bleeding, such as the copper IUD. In the copper IUD, we do expect you to have regular cycles. However, these cycles can be prolonged and again, very heavy. Sometimes also with certain kinds of birth control pills, as Dr. Wertheimer mentioned the other night, you can see some breakthrough bleeding or bleeding in the middle of the month when normally we shouldn't really see bleeding. Whenever we're evaluating heavy bleeding, we also always have to consider the possibility of a pregnancy or a miscarriage. And then lastly, a pelvic infection can also lead to irregular and heavier bleeding. So how do we go about evaluating excessive bleeding? We will always start with a very thorough history, and we want to understand the nature of the abnormal bleeding. How often are you bleeding? How much bleeding is there? What is your menstrual history? So is this something that has been going on for a long time, or is this something that's a newer issue? Do you have any other medical conditions? Are you taking any medications? Certain medications may interfere with the hormone pathway that leads to that normal cycle. And then also we always want to know if you're sexually active. Again, any evaluation of excessive bleeding is also going to include some blood tests. So we always are going to test your blood counts. We want to evaluate for anemia. We will often check your thyroid levels because a thyroid disorder can lead to abnormal bleeding as well. If we do think it's relevant, we may check for a bleeding disorder, and certain blood tests can check for some of those genetic conditions. And of course, we're always going to perform a pregnancy test. Depending on when your last pap smear was, we may perform a pap smear as well, because certain pap smear abnormalities could lead to abnormal bleeding too. And then the rest of the evaluation really depends on our suspected diagnosis. So do we think that you have a structural cause of your bleeding? And in that event, we are likely going to obtain some imaging. Our gold standard of imaging, and something that we're always going to start off with, is a pelvic ultrasound. And here you can see a picture of this on the side here. I know it just looks like a lot of black and white, but actually what we're looking at here is the picture of an ultrasound of a uterus. And within this uterus, you can see a very large fibroid over here. So pelvic ultrasound can help us see fibroids on the uterus. Sometimes we can also see polyps, and we can also see certain signs of adenomyosis on a pelvic ultrasound. Your doctor may want you to get a pelvic MRI for further evaluation, and that's usually used in very specific circumstances. Particularly, sometimes we can delineate exactly where fibroids are located, and we can also see signs of adenomyosis on a pelvic MRI. There are two other imaging modalities: a saline-infused sonogram or a hysterosalpingogram. And in both of these, we actually inject fluid into the uterine cavity. So either saline or contrast is injected into the uterine cavity, which thereby distends the uterine cavity and allows us to visualize any distortions in the cavity, for example, from a polyp or a fibroid that's projecting into the cavity. Another way that we can help diagnose what is causing excessive bleeding is a hysteroscopy. A hysteroscopy is a very minor procedure that is usually performed under anesthesia, but sometimes can also be performed in certain offices. in which we take a small camera and we pass it through the cervix and into the uterus. We also distend the cavity during a hysteroscopy, and then we can also visualize the cavity and see if there's any abnormalities in the cavity that can cause this abnormal bleeding. And then lastly, if we do suspect that there may be abnormal thickening of the uterine lining, we may perform an office procedure of an endometrial biopsy just to obtain a tissue sample of the lining of the uterus to assess for any abnormalities. So how do we go about treating excessive bleeding? There are many ways to treat excessive bleeding. And again, it all really depends on what we think is the underlying cause of the abnormal bleeding. But certain medications can help treat the abnormal bleeding. So for example, birth control pills, the depot shot, which is a progesterone shot, or a progesterone IUD can often help control and lessen heavy bleeding from periods. Additionally, NSAIDs, which is a category of medication including Advil, Motrin, ibuprofen, can sometimes help certainly reduce the pain from heavy periods, but also can even help reduce some of the bleeding from the heavy period. And there's another medication called the tranexamic acid, which is a medication that helps slow down bleeding by interfering with the breakdown of blood clots. We can perform a hysteroscopy, which allows us to remove polyps or fibroids from the uterus. Again, like I said before, it helps us diagnose, but it also can help us treat these issues. And then some of the other interventions are a little bit more invasive, but can be utilized as well. And so a uterine artery embolization is a procedure that's performed in the hospital by interventional radiologists. And essentially they place coils into the arteries that feed into the uterus, thereby reducing the blood supply to the uterus and overall reducing your bleeding. If you do have large fibroids can be removed through an abdominal surgery. And then if other methods have not been successful and you're finished with your childbearing years, and the last option is also to perform a hysterectomy and remove the uterus. So now we're going to move on to what can cause less than normal bleeding, or as we mentioned before, oligomenorrhea. Again, we look at ovulatory dysfunction. So I brought this diagram back on the side, which shows us, again, that hormone pathway. And any interference with this hormone pathway can also lead to less than normal bleeding. Again, I want to reiterate that irregular periods at the beginning of puberty and then towards menopause are all part of that normal and natural transition and don't necessarily require any intervention unless they're causing other issues such as heavy bleeding or anemia. PCOS, which has been mentioned in other presentations, is also a form of ovulatory dysfunction. And it's basically, again, a condition in which the body produces excess androgens, and that leads to irregular cycles and disruption of ovulation. We don't know exactly what the causes of PCOS, but it is thought to be largely genetic. However, certain environmental factors can exacerbate it. For example, obesity can exacerbate polycystic ovary syndrome. Certain birth control methods may lead to less than normal bleeding. So for example, certain birth control pills, you may not actually see a period every month, and that's okay as long as you're being fully compliant with taking your medication. Additionally, a hormonal IUD or progesterone IUD may lead to almost no bleeding at all, which is why it sometimes can be used to treat the heavy bleeding. But it's not concerning. It shouldn't be concerning if you're not having your regular period when you have a hormonal IUD. A thyroid disorder can often lead to irregular periods, again, because typically we think of it as disrupting this hormone pathway that leads to ovulation and having a regular cycle. And then certain lifestyle changes. So actually extreme changes in diet, weight, exercise, or stress are actually things that can affect all the way going back up to the hypothalamus, that center in the brain that starts off the hormone pathway. And so any of those things can also lead to irregular cycles. There is a benign pituitary tumor called a prolactinoma, and that is something that can lead to irregular or even not having any period at all. So that's something that we always do take into consideration as a possibility. And then there is premature ovarian insufficiency, which is essentially what some people think of as premature menopause, which means it's a loss of ovarian function, typically before the age of 40. Something that we always have to consider if you're having irregular or no bleeding from your period. And then lastly, in rare scenarios, sometimes we'll find that there's scarring of the uterine cavity, and that's typically occurs after you've had many procedures on the uterine cavity, such as DNCs. Sometimes can lead to scarring of the uterine cavity, and we may not see regular periods if that occurs. So now how do we evaluate this irregular or less than normal bleeding? Again, we're always going to start off with a very thorough history and a physical exam. We're going to obtain some blood tests. Again, we'll check your thyroid levels. We may check some reproductive hormone levels. So checking some of the hormones that are in this reproductive pathway to see if there's any signs that there may be premature ovarian insufficiency. We also will check some androgenic hormone levels to see if there are signs of polycystic ovary syndrome. Of course, anyone who's not having a period should always receive a pregnancy test. And then we're also going to check a prolactin level because, again, we always want to take into consideration the possibility of that pituitary tumor, which can lead to elevated prolactin levels and irregular or no periods. And then we may or may not choose to do some imaging depending on what we suspect. But again, we're always typically going to start with a pelvic ultrasound, and you can see a picture of some ultrasound images right here on the side. And in this case, we're not actually focusing as much on the uterus, but we're focusing on the ovaries, and we're looking for signs of things like polycystic ovary syndrome. We may, in a very specific scenario, if we do suspect that there may be a prolactinoma with an elevated prolactin level, we may obtain a brain MRI as well, but really only in that particular scenario. And then how do we go about treating irregular periods? So again, first and foremost, if we do suspect that it may just be part of the natural transition, the natural changes from starting at puberty or leading towards menopause, we may just choose to observe it. It may not require any intervention. We can help regulate periods with birth control, specifically with the birth control pills can often be used to help regulate periods, or the NuvaRing can also be helped to use to regulate the periods. If we do suspect premature ovarian insufficiency, then there are ways that we can replace some hormones that may be insufficient, and that can help lead to back to having regular periods again. And then, of course, we always talk about lifestyle changes. So as we had mentioned, one of the causes of irregular periods is certain lifestyle changes like diet, exercise, increased stress. And if any of those things we do suspect are the cause of irregular periods, we may address some of those in treating the irregular periods.
Dr. Joel, 1 minute warning.
So that's great because we are finished. So that about covers this very large topic. I'm sure there's still a lot of questions out there, but I'd be happy to answer some of those questions at the end of this session. And perhaps we can also address it at a later time. Thank you.
All right, so now we have our third panelist, Dr. Hani Yandorf. Dr. Yandorf completed her residency in OBGYN at Einstein Medical Center in Philadelphia. She remains on staff there as a general obstetrician and gynecologist, and she also serves on the Einstein Victor Center team, helping to prevent Jewish genetic diseases. Dr. Yandorf.
All right. First, I have to figure out how to share my screen. All right. Okay, so to end the session off and to end off a huge 3-night series, we're going to start talking about pelvic pain and contraception. I don't have anything, any financial disclosures to discuss. Some of the things we're going to touch upon today, we're going to talk about the causes of pelvic pain, the evaluation of pelvic pain, and how we manage pelvic pain. We're also going to then switch gears into contraception, talk about some of the different choices out there and some of the other clinical uses that we have for contraception. So let's start off with our discussion on pain. There are so many different kinds of pain out there. And when you're trying to figure out what's going on with somebody, you kind of have to be pretty specific in figuring out what exactly is going on and what kind of pain you're having. And so there's acute pain or chronic pain. Acute pain is pain that happens pretty suddenly. Chronic pain is pain that's been there and is ongoing. Cyclic pain or non-cyclic pain. So pain that occurs, regularly in a cyclic pattern once a month, kind of associated with your menstrual cycle, versus pain that's happening regardless of what part of your menstrual cycle you're up to. And then, we often deal with pelvic pain as it relates to our gynecologic organs, but don't forget there's lots of other organs there in the pelvis, and those organs also can cause pain as well. So let's quickly touch on acute pain. Acute pain is pain that occurs, suddenly. The onset is, it happens within the past 3 months. It's ongoing for the less than 3 months. Most of the time, acute pain happens because of an injury to the body, and that injury is often, pretty obvious, and we're able to determine what exactly is causing that pain. And once we kind of take care of that injury, we resolve the issue, and the pain kind of goes away. The important thing to know about acute pain is that most of the time acute pain is emergencies. And so whenever you're noticing that you're having acute pain, you really do want to make sure to seek care pretty immediately. Some gynecologic causes for acute pain are things like ectopic pregnancy, which is a pregnancy outside of the uterus, which if left untreated can result in death. A ruptured ovarian cyst, where you have, one of those follicles that was housing, an egg kind of ruptures open, and you can have some bleeding into the belly. An ovarian torsion, where the ovary will twist on itself, which, if left untreated, can lead to the death of the ovary. And some pelvic infections can also cause acute pain. And then there's the non-gynecologic causes of acute pain, things like appendicitis, diverticulitis, a urinary tract infection, i.e. infection in any of those other organs within the pelvis. Kidney stones as well can cause acute pain. But the bottom line is, if you are experiencing acute pain, you do want to make sure that you seek immediate care. Moving on to chronic pain. So chronic pain is a little bit more complicated. Chronic pain is pain that is ongoing. It lasts for more than 6 months. Most of the time with chronic pelvic pain, the initial injury or the initial cause of the pain has resolved. And what you're left with is a nervous system that, has refigured out how to, perceive threats and how to experience pain. And so you have this nervous system that has become overly sensitive towards pain, and it will overreact to various triggers that shouldn't necessarily cause that much pain. But now, because the nervous system is all ramped up from that initial injury that occurred who knows when, you now find yourself in a situation where you have lots of pain that we don't necessarily have, a reason for. And, what happens is that while you might have started off with an injury that caused this chronic pain, that injury goes away, and what you're left with is pain as the disease itself. So you oftentimes can't find an underlying cause for the pain. The pain itself is the disease that needs to be treated. It's very, very complicated. It's often multifactorial, very hard to diagnose, and very hard to treat. So first, we're going to start talking about some of the causes of chronic pain. We'll start with some of the gynecologic causes. The most common gynecologic cause of chronic pain is endometriosis and adenomyosis. And the reason I kind of clump these two together is, it's really a spectrum of the same thing. So endometriosis is, as Dr. Joel kind of talked about, the uterus has 3 layers. That outside shiny serosal layer, the bulk of the uterus is the muscle layer or the myometrium, and then the lining of the uterus or the endometrium. Now, the lining of the uterus, the endometrium, is the part of the uterus that is sensitive to hormones. That is the part that kind of, goes through all of the different changes within the menstrual cycle. And so, that layer of cells responds to hormones, gets thicker with hormones, and then ultimately is what bleeds at the end of the cycle with your period. And what happens with endometriosis is that those cells, those endometrial cells that should be lining the uterus, find themselves outside of the uterus. On the outside of the uterus itself, like on that serosal layer, sometimes they can find themselves on the ovaries, on any part of the abdominal cavity. It can wind up on top of the bladder, on top of the rectum. And so what you have is you have pain, that occurs. Mostly it gets, it can happen throughout the month, but it does tend to get worse with your period, because when you get your period, these endometriotic lesions, which shouldn't be there, are bleeding into your belly, onto your bladder, onto your rectum. And so a lot of women will experience, pain with voiding, pain with bowel movements, pain with intercourse. And that can happen, where women have pain really does depend on where they have their endometriotic lesions. Adenomyosis is very similar to this, but instead of the lining of the uterus being outside of the uterus, they kind of find themselves soaked into the muscle layer of the uterus itself. And I like to think of it as the uterus acting like a sponge almost. And so every month when the uterine lining bleeds, the lining itself kind of bleeds into the walls of the uterus, and the uterus itself becomes this spongy, boggy item that is full of blood. And that tends to make periods very, very painful. Some other gynecologic causes of chronic pain are things like fibroids. If they get to be too big or if they're in funny places, they can cause pain. Pelvic inflammatory disease or an infection in the pelvis can often leave in its wake, inflammation that will cause chronic pain. If you've had multiple surgeries or even just one surgery, you can wind up with scar tissue or adhesions that can cause pain. And then there's also a whole nother syndrome of vulvodynia or vestibulitis, which is basically pain on the outside of the vagina or, within the vaginal canal itself. And that is painful to the touch as well. There are, like I said, other organs within the pelvis, and these other organs can also cause pelvic pain. So within the urologic system, there's this condition called interstitial cystitis, which can often cause, these feelings of chronic, it feels like you have a urinary tract infection, you have pain when you pee, you have this increased frequency to pee, increased urgency for peeing, but there's no bacteria actually there. And that is a condition called interstitial cystitis. There's also chronic urinary tract infections, which can occur, which can lead to chronic pain. Within the GI system, there's irritable bowel syndrome or inflammatory bowel disease. All of these diseases can contribute. There's also something that's very interesting called myofascial pelvic pain, and that's something a lot of people don't realize, but our pelvic floor is made up of muscles, and those muscles in our pelvic floor, can tense up and can become injured, and the muscles of our pelvic floor themselves can cause us to have pain as well. And then oftentimes with chronic pelvic pain, there's a psychosocial component to it as well. So, if a woman has suffered physical or emotional or sexual abuse in the past, that can manifest itself as chronic pelvic pain in the future. What I do want to stress about chronic pelvic pain is that, unfortunately, like I mentioned before, there's no clear cause for this pain. And oftentimes we cannot identify a cause for the pain. And what we have to do is treat this pain like a disease or the disease that it is, and try and manage it from that standpoint. So what do we do, when you go to see your gynecologist and you're telling them that you have chronic pelvic pain? How is your gynecologist going to start evaluating that? So, the most important thing that we look at is the history and the physical exam. Because, and this is really important, because you want to come to your gynecologist with a very detailed history. They want to know, when do you have pain? Is it associated with your periods? Do you notice that you're having pain when you eat? Do you notice that you're having pain when you pee, when you have sex? What is causing your pain? When are you noticing the pain? Keeping a pain diary is very important and very helpful for your gynecologist when you come to be evaluated for your pelvic pain. The physical exam also can give the gynecologist lots of information about where this pain might be stemming from, and what that underlying cause might be. Laboratory studies are done. That includes pregnancy test, urine culture, vaginal swabs for infection as well. Oftentimes a pelvic ultrasound will be done. This can help us identify, are there any structural things within the ovaries, within the uterus? Are there fibroids in funny places? Do you have an ovarian mass that's causing pain? So pelvic ultrasound can often be helpful. The evaluation for chronic pelvic pain really isn't complete until you've gone to see, a GI and a urologist as well, so that they can evaluate those organs. They'll often do a cystoscopy, which is where they put a camera in the bladder to check the bladder and make sure there's, look for any pain syndromes, and also a colonoscopy where they look inside the colon and see if there's, any reason to have pain from a GI standpoint. And then finally, sometimes a gynecologist will do a laparoscopy, which is a surgery where they put a little camera through your belly button to take a look in your abdominal cavity to help them get some more information as to why you might be having pain. Most of the time, before we go ahead and do surgery for an evaluation standpoint of chronic pain, we will start to treat that pain first and see if we can kind of get that pain under control. Because don't forget, surgery comes with risks as well. And so before you want to subject somebody, oftentimes it's not going to change your management, what you find on that laparoscopy. You're going to treat it the same way regardless. And so what we tend to do is treat it first, and then if it's not working, then we can kind of proceed to laparoscopy to see if we're missing something. So what do we do to treat our chronic pelvic pain? So if we do manage to find an underlying cause of the pain, well, we go ahead and treat that and see if we can help the chronic pain, see if we can help the pain by treating that underlying cause. Most of the medications that we use, are kind of pretty standard throughout whatever it is that's causing the pain. But, our top two medications that we use for chronic pelvic pain are NSAIDs, or non-steroidal anti-inflammatory medications, along with birth control. And the reason we kind of use these two medications as our first line is because most of the time the chronic pelvic pain is caused by an inflammatory environment in your pelvis. And if we can use an anti-inflammatory medication, that oftentimes will help, calm down or cool off that pain. Additionally, birth control can be very helpful because oftentimes, like I said, the most common cause of that pelvic pain is the endometriosis. And if you can kind of suppress that endometrial tissue, then you suppress the bleeding that occurs, and you can help, treat or prevent that pain from occurring. Another medication that's often used to treat chronic pelvic pain is our antidepressants and anticonvulsants. And the reason we use these is because, it all stems back to what is causing that pelvic pain, right? And so what we say is that the pelvic pain, remember, the injury is no longer there, and the pain is because the central nervous system has somehow rewired itself into being hypersensitive. And so if we can kind of attack that central nervous system using our antidepressant medication, our anticonvulsive medications, we can somehow reprogram the central nervous system into, perceiving pain or perceiving triggers in a less painful way. And that's the goal there with antidepressant medication as well. Opioids are oftentimes, are rarely helpful. We try to avoid them as much as possible, because what happens is you'll end up prescribing an opioid to somebody. It won't really help with their pain, but then they'll have trouble coming off of that opioid. And so you've kind of given them an extra problem without actually solving the problem that they started off with. In addition to medication, there are other ways that we treat chronic pelvic pain. And this is where I really, really want to make a big push for pelvic floor physical therapy. Pelvic floor physical therapy is, an incredibly important treatment modality for chronic pelvic pain. And it's often an underutilized one because, people kind of think of it as, strange, and nobody really wants to go there. Nobody wants to, experience that. But the way I like to, think about it is that when you have pelvic pain, so whatever injury might have caused that pelvic pain to begin with, all of the muscles within your pelvis are kind of reacting to that. And the muscles in your pelvis tend to tighten up and get, really tense as a result of the fact that they're trying to protect itself from the injury that there was. And so the same way, if you have a shoulder injury, the muscles in your shoulder kind of tense up, and, before your orthopedic surgeon is going to go ahead and operate, they're going to send you to physical therapy first, so that, the physical therapist can hopefully figure or teach you and, train your muscles how to relax and reorient themselves in the appropriate way. So that way, you can fix the pain without surgery. And the same thing is kind of true when it comes to, the pelvic floor. So our pelvic floor muscles have, tensed up as a result of this pain. And the pelvic floor physical therapy is there to help teach you how to relax those pelvic floor muscles and, teach you how to reorient those pelvic floor muscles so that they're not causing you this pain anymore. And so, if you can kind of get over that ick factor of somebody kind of being in your pelvis, it really is a wonderful modality and has helped many people with their chronic pelvic pain. In addition to that, there's cognitive behavioral therapy and sex therapy, which also, are big helpful options for chronic pelvic pain. And finally, if nothing is working, there's always surgery. Most of the time the surgery that's done is a hysterectomy, and which is removal of the uterus and also removal of the ovaries. The problem with surgery is that even though you're taking out that uterus and you're taking out that ovaries, a lot of the times it doesn't actually help with the pain, because like we said, it's not a problem with the uterus and the ovaries anymore. It's a problem with how the nervous system in your pelvis perceives triggers. And so even if you remove the uterus and remove the ovaries, you're still left with a pelvis full of nerves that doesn't really know how to handle themselves. And you still, sometimes women will still have pain after surgery. The bottom line with chronic pelvic pain is that, you got to just keep on hoping. Don't lose hope. Chronic pelvic pain is frustrating. It's frustrating for patients because they've oftentimes gone to multiple physicians to try and treat this pain. Nobody can find an answer for them. It's very frustrating for patients. It's frustrating for physicians too, because, we're out there. All we want to do is help, and we feel like our hands are tied. There's very little that we can do to help, and it's frustrating for physicians as well. Oftentimes the best way to treat the chronic pelvic pain is through a multidisciplinary treatment modality using NSAIDs and birth control, along with pelvic floor physical therapy, along with cognitive behavioral therapy, kind of using everything all together is really the most effective way of treating chronic pelvic pain. And the one thing to just kind of think about and remember is that, your pelvic pain didn't develop overnight, and you're not going to be able to heal it overnight. It's a slow process. It takes time. Don't expect instant results. Pick your treatment modality, stick with it, and ultimately you can see results. Okay, we're going to move on to contraception now. So there are so many different kinds of contraceptives out there, and there are so many different uses for contraception as well. We don't just use contraception for birth control. We use it often as our first-line treatment for major gynecologic conditions. Like Dr. Joel was talking about earlier tonight, we use it to treat abnormal bleeding, heavy bleeding, irregular bleeding. We use it to treat painful periods, pelvic pain. We also use contraception to treat things like acne and extra hair growth and mood swings and PMS and all of that stuff. So contraception is more than just birth control. So first, a quick overview of the different types, and then we'll kind of delve into each type in specific. So there are the short-acting contraceptives. Those are things like the combined oral contraceptives, progesterone-only contraceptives, the patch, the ring, Depo-Provera, which is kind of an in-between thing. And the longer acting reversible contraceptives, these are things like the IUD and the next one on. We'll start our conversation off with the birth control pills because that's the thing that most people are most familiar with. There's two overall categories of birth control pills. There's the combined birth control pills and the progesterone-only birth control pills. The combined birth control pills contain both estrogen and progesterone, two hormones, versus the progesterone-only pills, which only contains progesterone. With the combined birth control pills, there are so many different options out there. It all uses the same type of estrogen and ethinyl estradiol, but the dosing of that estrogen does vary with different pills. The progesterone comes in many different flavors. There are so many different types of progesterone within the birth control pills. And because there are so many different types of combined oral contraceptives, the reason that there are so many is because there's so many different types of women. And each type of combined oral contraceptive will have its own side effect profile, which, is great because every woman out there kind of has different side effects that they're okay with and are not okay with. And so you can kind of pick your combined oral contraceptive based on, how it makes you feel. Oftentimes it is a trial and error, process until you find the one that's right for you, but ultimately you can find the one that's right for you. On the flip side, the progesterone only pills, really there's just one kind of progesterone out there. There's one dose out there. And that's really all that there is for the progesterone only pills. With the combined oral contraceptives, the schedule for taking them is a little bit more flexible. You do have to take a pill every single day, but if you're off by a couple hours, it really shouldn't mess you up that much. With the progesterone only pills, though, it's much stricter. You really should take it every 24 hours. You shouldn't be off by more than an hour. If you are, you might notice that you don't have as good contraception, and you might also start to notice some breakthrough bleeding because of that. With the combined oral contraceptives, you got to be careful about underlying medical conditions. If a woman has high blood pressure, a history of blood clots, if she's a smoker and she's over 35 years old, if she has migraines with an aura, all of these conditions, put a woman at a higher risk when they take estrogen. It increases their risk for having a stroke with estrogen. And so we tend to shy away from the combined birth control pills in these settings. The progesterone only pills are really safe in the setting of many of these underlying medical conditions. And so those, are easier to use when a woman has other medical issues that are there. The combined birth control pills can have more side effects because there are two hormones there. The progesterone only may have less side effects. And with the combined birth control pills, the way that they're taken is that you have 3 weeks of an active pill, which has both hormones in it, and then 1 week of a placebo pill, which is a sugar pill. Most of the time it does contain iron. And the way it works is that, like Dr. Wertheimer spoke about in that first night, the reason you get your period is because of a withdrawal from your hormones. And so you have 3 weeks where you're getting hormones, and then that last week you're not getting any hormones. You withdraw from the hormones and you get a period. And so the combined birth control pill kind of mimics a normal menstrual cycle where you have 3 weeks of no bleeding and then 1 week of period bleeding. The progesterone only pill on the flip side, all it has is active pills. There are no placebo pills. There are no sugar pills. About half of women will continue to get a regular period on these progesterone only pills, but the other half of women will really sometimes not get any period at all, sometimes have irregular bleeding or spotting throughout the month. The patch and the ring are very similar to the combined birth control pills in that they contain both estrogen and progesterone. But they're a little bit easier to take, or a little bit longer acting. The patch you switch once a week, the ring you switch once every 3 weeks. Now for my most favorite question of all, can I skip my period on the pill? And this is the question that I get over and over again. And the answer is yes, absolutely. You can skip your period on the pill for as long as you want. It's safe, it's not harmful. Women often worry, well, if I'm skipping my periods, does that mean that, there's all this blood building up inside of my uterus and I'm not expelling it? And the answer is no. So if you're not getting your period, and you're not on any medication, but you're just not getting your period, well, then yes, you do have to worry about the fact that you're not bleeding anything out and you can have an overgrowth of that lining of your uterus. But if you're not getting your period because we're giving you a pill that's stopping your period from coming, well, then you don't have to worry about it. And here's the reason, because those birth control pills, what they do, and this, again, Dr. Wertheimer kind of touched on that first night, the way the birth control pill works is that the hormones that we're giving you, they're kind of staying there and they're stabilizing that lining of your uterus for you. They're keeping that uterine lining nice and thin and stable. And so even though you're not getting your period, there's nothing there that's, overgrowing. So it's a perfectly safe option to skip your period on the pill. And then also the patch and the ring as well. You can kind of skip that week off, skip your period. The one caveat that I do like to mention is that, some women are very sensitive to this. And, oftentimes if you skip your period for too many months in a row, you might find that you have some breakthrough bleeding. Now, breakthrough bleeding is not harmful. It's not dangerous, but it can be very annoying. And so oftentimes, most women can make it 3 months in a row, without getting a period before they start to have breakthrough bleeding. So I generally like to counsel patients give it 3 months and then, let yourself get a period after that and start fresh for another 3-month cycle. You can always test your body's limits, see how far it'll let you go before you start to notice that breakthrough bleeding and kind of use that as your guide. Okay, moving on to Depo-Provera. This is a progesterone-only medication, which means that it is safe for women, regardless of underlying medical conditions. It's an injection that you get once every 3 months. The thing to note about Depo is that, for women who've been on it for many, many, many months, a lot of times it can, stop their period altogether. But for some women, especially when you first get started on Depo, you might note that you do have, a bunch of bleeding in the beginning, some breakthrough bleeding, sometimes heavier bleeding, sometimes it can last for, a month or more. And so that's kind of something to know about when you start the Depo. And the other thing to know about Depo is that it can actually take up to a year to get out of your system. So if this is something that you want to do only for a couple of months before you want to go ahead and start having a family, or start trying to conceive, it's probably not the greatest choice, because it can take a whole year for you to resume fertility, for you to resume ovulation. And so just, kind of keep that in mind when you're getting that injection, that it might take a while to get out of your system. Okay, moving on to the Nexplanon. The Nexplanon is one of our long-acting reversible contraceptives. It is a subdermal implant, which means that it is a rod that is placed under your skin, and it solely releases a hormone throughout, the month. The hormone is a progesterone only. It's a progesterone only hormone, and so, again, it's safe for women with underlying medical conditions. It is FDA approved for 4 years. Studies show that it actually lasts up to 5 years. And with the Nexplanon, the bleeding profile is variable. About a third of women will, continue to have a monthly cycle. A third of women will have no bleeding whatsoever for the entire time the Nexplanon is in, and a third of women will just have irregular bleeding throughout the month that is, unpredictable. Okay, moving on to IUDs. So this is kind of an overview slide, and then we'll kind of delve a little bit deeper. So IUDs, there are 2 major kinds. There is the levonorgestrel IUD, which is the hormonal IUD, and then there's the copper IUD, which is the non-hormonal IUD. The levonorgestrel IUD, most commonly known as Mirena, but also there are also other brands, including Liletta. This IUD does contain progesterone. It only contains progesterone, so it is safe for women, regardless of underlying medical issues. This IUD lasts for 7 years. For most women who take this IUD or have this IUD, they have very light periods, and some women will not have a period at all for the full 7 years that they're on it. For the copper IUD, so that one is a hormone-free contraceptive option. It lasts for up to 12 years. With the copper IUD, you can have periods that are heavier, that can be a little bit more crampy. So if you're somebody who already has heavy crampy periods, this IUD may not be a great choice for you. When it comes to IUDs, one of the most common issues that comes up is the spotting that can happen. So with an IUD, oftentimes for the first 3 to 6 months after insertion, you can have spotting. And sometimes the spotting can be a little bit heavy, sometimes it can be prolonged. One thing I do want to stress is that, if you're having spotting within that first 3 to 6 months, don't lose hope. Don't pull your IUD out yourself. Speak to your gynecologist. We have tricks up our sleeves that we can use to help stop that spotting. And a lot of times that works. And once you can make it past that annoying 3 to 6 month initial time, you do notice that the spotting kind of goes away. And then you have, 6.5 more years of beautiful period-free life. And so, we can use anti-inflammatory medications to help stop the spotting. Often if we, put you on a combined oral contraceptive or a progesterone-only oral contraceptive while you make that transition to getting used to that IUD, we can often help, prevent those spotting months and put you in a good place. IUDs are safe regardless of some of the other medical conditions that you might have. If you do want to have a family prior to the full 7 or 12 years, you can pull it out sooner. Well, not you, but you should go to a gynecologist and they can pull it out for you sooner than that. And once the IUD is removed, you do have an immediate resumption to fertility. So it's not like the DEPA, which can take a year to come out of your system. Once the IUD is out, your body starts to pick back up and, start that process of, ovulation again. Something to keep in mind is that, even though we talk about IUDs most of the time for contraception, it actually is one of our first line treatments for many gynecologic issues like heavy bleeding, like irregular bleeding, like pelvic pain and painful periods. IUDs really do a wonderful job. They do the great trick and are very helpful in treatment of many of our gynecologic issues.
Dr. Yandro? Oh, you finished. Okay. Great.
Yeah.
All right, so thank you to all of our presenters. It was very informative. We're now going to go ahead into the Q&A portion, just address some of our questions to the panelists. So the first question we have is, what age should one freeze eggs by?
I assume that's going to be towards me. So there really isn't a perfect age. I generally tell people that age 30 to 34 is kind of the sweet spot for egg freezing, because that's the age in which the majority of the eggs are healthy, and most women are still able to produce a lot of eggs or a nice amount of eggs in a single cycle. And even if they're not, most of those eggs are going to be good, so they're not as handicapped by the lower numbers. Many women choose to freeze their eggs below 30. I certainly have a fair number of patients who have come to me in, between 25 and 30. It's a personal choice, but generally what I tell them is that there isn't usually a lot of change between 25 and, let's say, 32. And so it isn't as urgent. And if they decided they wanted to wait a few years to see what happens in their social life or see what happens with their life in general, that they're not really risking a lot. So there are certainly women who choose to freeze their eggs early. And then, I have many that come to me between the ages of 30 and 34, but actually a fair number, almost the majority of my patients are 35 and up. And there really isn't, just because you're 36 or 37 or 39 or even 40 or 41 doesn't mean you missed the boat on being able to freeze eggs. And, back to what I said earlier, getting the information and having the conversation allows you to stop guessing about whether this is something that's going to be helpful for you, whether you're too old or you're too young, and take the information that's related to you as an individual and your body and your goals and your egg supply, and be able to really make an informed decision as opposed to sort of guessing or assuming or hoping that something's going to be one way or the other.
Right. Follow-up question to that is, what is the average number of eggs one should have to successfully get pregnant?
Okay, so that's going to go it's going to be a very similar answer. It really depends. It's highly dependent on age. So typically for women who are, let's say 34 or younger, ideally you want to shoot for at minimum 8 to 12. That's going to give you like a 60 to 75% chance of at least one baby. But some women want to have 20 or more because they want to have a 90% chance, or they want to be able to feel relatively comfortable that they could have 2 babies from those frozen eggs. And the truth is, no matter how many eggs you freeze, it's never a guarantee. So to most people are limited by their resources and how many cycles they can do. Somebody who's 35 to 37, 12 to 15 eggs is about the same 60 to 75% chance. 37 to 39, it's more like 15 to 17. And then 40 and above, really to get that 60 to 75% chance, you're talking about getting close to 20 eggs, which is generally very challenging for women at that age group.
Okay, and then last egg-related question. If a woman isn't getting her periods, is she still preserving her eggs?
That's a great question. I think I also addressed it maybe once or twice on the chat, and I saw it came up a bunch. Back to, if you think about how the menstrual cycle works, there's a group of eggs that comes to the surface each month. The brain sends the message to select one of those eggs to be grown and matured for ovulation, and the rest of the eggs that were not selected just get discarded. And that's how we're churning through our eggs so quickly, right? We started with millions of eggs, and a few decades later, we end up with none. Where are they all going? They're being discarded relatively rapidly. So women who are on birth control pills, or who are pregnant, or who are not getting regular periods, or who have an IUD in, they are not actually preserving their eggs. This process of the eggs coming to the surface and then being discarded is still happening. The birth control pills, for example, what they do is disrupt that communication between the brain and the ovary. So no single egg gets selected for ovulation, but those little eggs that come up, and then they get discarded again. So there's a little bit of a difference between ovulation and what's happening in the ovaries and what's happening for the uterus and the shedding of the lining of the uterus. I like to think of the uterus as just a foot soldier. It does what the hormones tell it to. So if you take progesterone and then you stop progesterone, the uterus is going to bleed. But that doesn't mean that hormonally something else is, that something is happening hormonally on the level of the ovary. So unfortunately, skipping your periods does not save your eggs in any way.
All right, thank you. And now this question for Dr. Yanda, for Dr. Joel. So we had a question about postpartum contraception, if one of you don't mind addressing that.
Yeah, I could take that one. So postpartum contraception is, very variable. It depends kind of on a lot of different, personal things within your life. So first and foremost is that for the first 4 to 6 weeks after you deliver, your blood really wants to clot, because that's kind of how you stop bleeding after you've had a delivery. And so we do veer away from any birth control containing estrogen within that first 4 to 6 week period. And the reason is because estrogen also will cause your blood to clot. And so if you have both of those factors there for you, then you put yourself at a higher risk of developing blood clots, which can be pretty lethal. And so, no estrogen containing contraceptives are used during that first 4 to 6 week period. After that, it kind of depends on, what is going on. So if you wanted, a progesterone only contraceptive that lasts from the get-go, you can definitely get that started right away. A lot of women who are nursing will, take the mini pill. They enjoy the mini pill because, there's like this not good data about effects of estrogen on breastfeeding. And so if you're breastfeeding, oftentimes people will want to steer away from estrogen as well. So they'll take the mini pill. The problem becomes, if you're a busy mom with a new baby and maybe some other children out there and a job, how do you remember to take a pill every single day? And even more so, how do you remember to do it every 24 hours on the dot? And so a lot of women will actually, choose a little bit more long-acting contraceptives. Lots of women will go for an IUD at that point. Whether you want a Mirena IUD, which has hormones, or, a copper IUD, which doesn't have hormones, is also very, very personal. Some women don't mind having a monthly period. Some women don't mind having, heavy bleeding or a little bit of a more crampy period. And for those women, a non-hormonal type is what they're looking for. Some women are, looking to not have a period for 7 years, and the hormonal IUD really does work really well, to keep that at bay. So, the bottom line is there are lots of good choices out there. And it all depends on, what you're looking for in your life.
Okay, thank you. And then one other question. Some people wanted to know about getting pregnant without intervention with PCOS.
I guess I'll take that question. So PCOS, one of the hallmarks of PCOS, like we discussed yesterday, is ovulatory dysfunction, that the ovulation is happening irregularly or in a dysfunctional way. You certainly can get pregnant because occasionally women who have PCOS will ovulate, right? If you get your period every 60 days, then on day, 54, or 44, sorry, 46. Oh, there my math is getting bad towards the end of the night. Day 46, you may ovulate, but if that's happening every 46 days or so, you know, it's very hard to know exactly when the ovulation is happening. So I've had plenty of patients who have PCOS who are able to conceive without intervention. It's just challenging and difficult. And if you're only getting 1 or 2 periods a year, then you literally have 1 or 2 opportunities to conceive in an entire year period. And so actually one of my pet peeves is having a patient who comes to see me who says, oh, my husband and I have been trying to conceive for a year. And I say, okay, tell me about your periods. And they literally haven't had a period in an entire year. So they have not actually been trying to conceive. So it certainly can happen, especially in women who have PCOS who have maybe more regular periods. But the ovulation induction treatment is what's going to be so helpful for these women to be able to induce ovulation in a more predictable way so that you can know when to have appropriately timed intercourse and really increase your chances of having a child.
All right, so if there are no further questions, Dr. Wertheimer, would you like to go ahead and wrap up?
Yes, so just wanted to say thank you to all our speakers, Dr. Yondorf, Dr. Joel, and Dr. Maslow, and our moderator, Jackie Benayoun. And wanted to say thank you really to the whole JOWMA board and the Women's Health Initiative board and moderators, Eliana Fine, who is the CEO of JOWMA, for helping make this happen, Dr. Batsheva Lerner-Maslow, Dr. Mimi Knoll, Dr. Mira Hellman-Ostrov, Miriam Andrusier, and all our moderators every night. It's really been amazing. We are so happy that everybody joined 3 nights in a row, and stay tuned for more specialized lectures every month. Some of these topics were really big and you guys had a lot of questions. We're gonna try and address them on a more detailed level. And then this JOWMA is a nonprofit. Everything that was done here was done with volunteering of these busy doctors. So if you guys want to help us out by improving women's health awareness, you can donate at jowma.org/donate. Thank you and have a good night.